I've been living with HIV for 13 years.
I've been living with HIV for 2.5 years.
I was diagnosed HIV positive December 20th, 1995.
I've been living with HIV now for 15 years.
It's been almost 9 years since I've been diagnosed.
I vaguely remember my clinician telling me, you know, you're AIDS defined.
HIV, when I was diagnosed, is devastating.
The results came back positive, and my reaction was I fainted.
For a while there, I stopped dreaming. I didn't want to go any further, like continue with school or do anything else, because I always knew I would be dead by this time next month, this time next year or something.
To live with HIV is one's worst nightmare.
These are just a few of the faces of HIV and AIDS in America. Somewhere between 850,000 and 950,000 people are infected with HIV in the United States today. Thanks to advances in treatment, fewer Americans will now die from AIDS, but that means more will live longer with chronic HIV illness.
The real challenge is to get those really complicated and effective treatments to the people that most need them.
In this video, you'll see how clinics have successfully used specific strategies and models to dramatically improve the quality of care for HIV clients. We'll highlight the resources and tools developed during the Improving HIV Care Collaboratives, resources and tools now available for you to replicate and adapt in your own practice. The collaboratives may be over, but the collaboration continues. It's all about working together for better care.
We have the opportunity here to contribute to science, to contribute to the knowledge that people have about how you provide high-quality health care services to a disenfranchised population.
HRSA's HIV/AIDS Bureau, HAB, and the Institute for Healthcare Improvement, IHI, saw the importance of bringing providers together in a collaboration to ensure accessible, quality health care and services, and to produce rapid improvement in the care of people with HIV and AIDS, who are thought of here not as patients, but as clients.
It's not just about medicine, it really is all the things that bring someone into care. So when we think about improving the quality of care for people living with HIV that are disproportionately affected by the disease, then we really have to think much more broadly than we usually have.
There are 3 models used here to improve care. The learning model makes providers part of a nationwide network of experts and fellow learners, forming collaboratives for a year of intensive learning. This includes testing and implementing changes back at their individual sites with ongoing support from the network. The care model outlines the 6 key elements of good chronic care. Patient self-management, where the patient works with the clinical team and plays a central role in his or her treatment. Decision support, which involves training and support for the clinical team so members understand and apply the most current knowledge to help their clients. Clinical information systems ensure that clinicians have easy access to timely, relevant information about each client in the practice and the population of patients as a whole through the use of a registry and other tools. Delivery system design shifts the emphasis from acute client visits to planned visits and expands staff member roles to accommodate. Organization of healthcare integrates this new way of doing things into the very fabric of the organization, with senior leaders visibly supporting and promoting the effort. And community completes the care model. State and local health departments, churches, businesses and clubs, schools and hospitals can help support the goals of the clinic teams with resources, expertise, and physical space. While the care model describes what elements must be in place, the improvement model defines how to test and implement changes at an accelerated pace. By asking 3 fundamental questions: what are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? Clinic teams can set aims, define measures that will tell them if the changes are having the intended effect, and decide on which changes to try out. The second part of the improvement model is the Plan, Do, Study, Act, or PDSA cycle, a way to quickly test changes to see how they work. Teams plan a change, try it out on a small scale, reflect on the results, and modify the change as necessary. Teams then repeat these rapid cycles, gradually refining the change until it works.
Along the way, we have created documents, manuals, curricula. This effort is really about identifying strategies that have been successful, tools that have been useful, and spreading them to all of our grantees through a variety of mechanisms.
I was able to get tools that I had never had before. I didn't have to reinvent the wheel, and that was huge
over time, you'll see an improvement in the quality of care that your clients get. You'll see an improvement in how your staff feels they're working with clients, and they'll see successes. And when staff see successes, they work better.
The bottom line is we're here to save lives, and that's why I got into medicine in the first place. And so this allows me a new tool and a new way to go about doing that.
I've seen a lot of changes, and I just want to thank them, you know, for having the commitment and the concern and the desire to want to be in on the fight against HIV.
For more information, contact the National Quality Center or HRSA's HIV/AIDS Bureau. There are many valuable resources and tools available to you now that we're working together for better care.